Hey everyone, this is Dr. Kristen Adorno. I am the current ultrasound fellow at Cooper University Hospital, and we're going to be going through a quick case from the Coop on a patient with dyspnea with an obvious focus on the point of care ultrasound. So this is a 38-year-old female who came in with dyspnea for the last roughly 3 days progressively. She only has a history of end-stage renal disease on peritoneal dialysis, but she's actually been unable to do her dialysis for the last roughly 3 days. Due to her just kind of generalized fatigue and really severe progressive dyspnea. These are her vitals on initial presentation. Notably, her blood pressure was okay. She was significantly tachycardic to the 130s with a pretty impressive respiratory rate of at least the high 20s. She was satting okay on room air, and she was notably afebrile. On exam, she was pretty ill-appearing, pale, visibly tachypnic, and just very fatigued, really unable to even move herself from a wheelchair to the bed on her own. She had a clear lung exam notably, but was just tachycardic, tachypnic, and clear heart sounds. So our differential, obviously, we have a ill-appearing patient who is tachycardic, and our first thought is always going to be sepsis, although she had no focal symptoms. But really, I want you to kind of emphasize here is that she was tachypnic, tachycardic, and had clear lungs. So that gives you a really pretty finite differential, which I think whenever I have patients like this is one of the patients that I almost every time I'm going to reach for my ultrasound. Because if you notice here, the kind of short differential of a really visibly tachypnic, short of breath patient with clear lung sounds, most of these things on your differential you can kind of help narrow down with your ultrasound. So we can look for signs of right heart strain, whether it be acute or chronic, for your PE and your pulmonary hypertension. We can see signs of pericardial effusion or tamponade, and that at least helps rule out 3 of these things. And then of course you can get, an AccuCheck and some blood work to look at the rest of your differential. But whenever I have someone who's pretty ill appearing, especially if they have a history of malignancy or even end-stage renal disease, I'm going to look and just make sure I can rule out some of these other things going on. So, of course, we've got our point of care ultrasound to the rescue. So we grab the cardiac probe and take a look at this patient's heart. And there's a few kind of visible things you should see immediately here. So first, before we hone in on the abnormal findings, I always just make sure that I have a good orientation and I see everything I want to see, and it's a good quality view. So we do have our peristernal long axis view here. And first I'll just notice we do have our left atrium, our mitral valve, our left ventricle, good aortic outflow tract here, and then we notice our right ventricle here. I do see a bit of the descending aorta back here, so I know that I have a pretty good quality image. Then I'm going to focus on our E's, so I see a pretty good ejection fraction. I can see the left ventricle fairly well here, and it does look like we have a good squeeze. I see our right ventricle is roughly 1 to 1 to 1 with the left atrium and the aortic outflow tract. And now I'm really going to focus then on the third kind of most abnormal finding here, which will be this pericardial effusion, which you can see this anechoic stripe going circumferentially around the heart. And initially I noticed that it is fairly large. I always try and find the biggest pocket of it to assess the size. From 1 to 2 centimeters is going to be a moderate sized effusion, and then greater than 2 will be a large effusion. So this is at least probably moderate to large here. I see that it is 1, maybe 2 centimeters in the largest breadth across. So we'll move our probe over and get our peristernal short axis view here. Again, we can see that in the left ventricle, see the papillary muscles, the squeeze looks pretty good here. Right ventricle looks pretty appropriate comparatively, and we still see this effusion circumferentially around the heart. We've got our apical 4-chamber view here. Not the best quality image, but I can still recognize our 4 chambers, our left atrium, left ventricle, right atrium, right ventricle, and a bit of both of the valves coming kind of in and out. And again, I recognize this effusion circumferentially here, this stripe of anechoic fluid. Lastly, we're going to get our subxiphoid view, which really does show the pocket most impressively. Here I can say it's absolutely going to be a large effusion. It looks even more like 3 centimeters when I compare it to our measurements on the side here. Otherwise, pretty good view of the heart. All right, so obviously this is going to be our question we're asking ourselves is, we see this large pericardial effusion in this patient who's otherwise not doing very well, with borderline unstable vitals, with a profound tachycardia and tachypnea. So is she in tamponade? How do we assess this? I usually start looking at the IVC. So if you have a plethoric IVC, meaning an IVC that's dilated with minimal respiratory variation, that's going to be your most sensitive finding for tamponade. AKA, if you have a plethoric kind of distended IVC, then you cannot rule out the diagnosis of tamponade. First, whenever I'm looking for the IVC, I just want to make sure again that I have a good quality image. And I want to prove to myself that this vessel is indeed the inferior vena cava and not the aorta. So to do that, I want to see either one of two things. I want to see the IVC draining into the right atrium, which I do see it here, and I want to see the hepatic vein draining into the IVC. Either one of these findings is suitable to be sure that you're looking at the IVC. Both is better, but I don't really see the hepatic vein draining in here. It's probably coming right here, but I at least see that the IVC is draining into the right atrium, so I can prove that this is indeed the correct vessel. Then I want to look at the size of it, which compared to these lines on the side here, it does look roughly 2 centimeters across. So it would be distended, and I see very minimal respiratory variation here. So this is pretty concerning, and I can't, at least right now, rule out tamponade since this is sensitive. So I can't say for sure that this is tamponade yet, but it's still a very viable option given the appearance of the IVC. I then want to try and find a more specific finding. Since I can't rule it out, how can I rule it in? Usually what I want to do is I often will start with this peristernal long axis view. I just want to find a view where I can really adequately look at the right ventricle free wall in the setting of the mitral valve. And the reason for this is your most specific finding for tamponade is going to be collapse of the RV free wall in diastole. So looking at the mitral valve is very helpful because if the mitral valve is open, then we know that that is going to be in diastole. So if we're really going to kind of gauge our eye between these two things, so the anterior leaflet of our mitral valve and the right ventricle free wall up here. And I really want to try and see is if when the valve is open, i.e. when the heart is in diastole, is that when the RV free wall is collapsing? Sometimes it can be pretty tricky to do when a patient is tachycardic. So your options are really to, one, you can pause the clip and kind of cine through and go through it more slowly to assess that. Is this collapse here happening while the valve is open? Alternatively, sometimes I'll talk out loud to myself and I'll try and say out loud when the valve is open so that I can kind of gauge the right ventricle free wall with my eyes while I'm just hearing myself say the word. So with the fear of sounding crazy, I'll just look at the valve here and I'll just say open, 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 open like that and try and gauge the free wall while I'm doing that. Your third option, if you're having a hard time doing it when this patient is tachycardic, is you could do Mmode. So what Mmode does is it really draws a line and shortens your frame of the ultrasound to just looking over where this line is, and it's going to look at that line over time. You want to make sure first that you have a good image. So you want to draw your Mmode through both your RV free wall and the anterior leaflet of your mitral valve. And then you want to look down at these horizontal lines here and try and see which lines correlate to which structures. The depth on the side is going to be your most helpful marker for this. So I see the right ventricle free wall up here is roughly around the 5 centimeter mark. So I know that must correlate to this line over here going across. I then want to look at the anterior leaflet of the mitral valve, which is going to be this line here, which is roughly around the 10 centimeter mark. So that must correlate to this squiggly line here. I then want to make sure that my view is adequate. So I want to see that I see particularly the mitral valve the entire time with this nice kind of waveform, because occasionally if you're off axis you can have the valve disappear and you won't have a perfectly adequate image. So I'd say that this is an adequate image here and that I see both lines pretty well all the way across. I then want to make my interpretation. Since this is the RV free wall, whenever it goes down, that's going to be when it is collapsing. So whenever this line dips down, it's collapsing. So it's collapsing here and it's collapsing here. And then when I look at the anterior leaflet of my mitral valve here, and I'll appreciate that whenever it's going up, that is going to be when the valve is open, and that's going to be when the heart is in diastole. So here, the heart, it's going up, so we're in diastole, valve is open here, diastole, valve is open here, diastole. And I did add some markers here just to make it a little bit more clear that you can see when it's dipping down, this is when the right free wall is collapsing, and when this line is dipping up, that's when the mitral valve is open. And then you want to just look at the timing of what is happening at the same time here. And I already drew it out for you, but you can see that when the mitral valve is open, we do in fact see the right ventricle free wall collapsing. So since this is timed well that we see RV free wall collapsing diastole, this is consistent with sonographic findings of tamponade. So for this particular patient, we performed this ultrasound. We were naturally concerned that this patient was in fact in tamponade, given her ill appearance, her significant tachycardia, and these findings. So we spoke with cardiology, who came down, repeated the ultrasound, found the same thing, and then took the patient for pericardiocentesis in the morning. They ended up getting off actually almost 2 liters of fluid, and they took opening and closing pressures of the pericardial sac and found significant improvement after the procedure, with really immediate resolution of the patient's vital signs and immediate symptomatic relief, thus confirming that this patient was indeed in tamponade. So things I really want you to take away from this quick talk are whenever you have a patient who is tachypnic, tachycardic, maybe hypotensive, and really with clear lungs, it's a really great time to get your point of care ultrasound, because you can imagine how if this patient had gone down the route of a sepsis workup or even a PE workup, it could have been a very delayed diagnosis of her tamponade or even missed entirely. Pericardial effusions are really not something that you want to be picking up on CAT scan. Always when you're worried about a pericardial effusion, make sure that you do get visualization of the IVC. First confirm that you're looking at the IVC and then just see if it is plethoric, just as that is the most sensitive finding of tamponade. And then when you're trying to rule in tamponade, really visualize that right ventricle free wall and assess whether or not it's collapsing in diastole, and consider using Mmode if you're having a hard time assessing due to the tachycardia. Anyway, that's all I've got for this case. Please reach out if you got any questions, and thanks for your time.